So good evening, everyone, and welcome to our April IPHA Member Town Hall. And thank you again for joining us. And as a reminder that our monthly town halls for 2021 are brought to us by our exclusive sponsor, QS1. And we thank them for their ongoing support of the association, and in particular, their support for the town halls. Our program this evening is COVID vaccine legislative concerns, and we know there's been a lot of policy changes over the last year, and we're glad to have our IPHA Region 4 Director, Jay Bogdan, who is also an attorney, and to take us through the presentation this evening. So I'll turn it over to Jay.
Thank you, Garth. Thank you for letting me present. What I did here was I pulled together a bunch of things I thought that would be of interest to pharmacists, some things that are kind of current emergency use. We'll talk a little bit about that. We'll talk about mandatory vaccinations in the workplace and other things related to COVID vaccine and vaccinations in general. If anybody has anything to add, feel free. Garth, if you want to chime in, if there's things you have, maybe that could update some of the slides, that's fine. I've tried to get this as current as possible, but there might be some things that some people want to know about, or maybe things you could share, or anybody else could share. So with that said, here we go. All right, COVID vaccine, 19 vaccination regulatory guidelines. That's what I titled this. In the interest of disclosures, I declare no conflicts of interest, no financial interest, company, product, service in this program, including grants, employment, gifts, stock holdings, and honorarium. Garth, can I ask you, how can I get rid of the, there we go, hide the thumbnail video, okay. The goal here is for pharmacists and technicians' objectives, all right? At the conclusion of this program, the pharmacist will be able to, one, define the emergency use authorization and recognize vaccines that are released under the FDA's emergency use authorization for COVID-19. Two, explain the employer-employee relationship when it comes to mandating vaccinations for employees. And three, describe proper procedure according to recent guidelines for supervising a pharmacy technician during the administration of COVID-19 vaccines. Here's some of the pre-test questions. So when we get through this, you should know the answer to this. What is an emergency use authorization? A, quick FDA approval of vaccine medications for immediate use. B, the use of unapproved vaccine medications in an emergency when there are no other available treatment options. C, the use of previously approved medication vaccines for an emergent situation. True, false. Employers can mandate that their employees get the COVID-19 vaccine. True or false, it is currently not permissible to obtain extra doses of vaccine from vials for administration. And true, false, pharmacy technicians can independently administer the COVID-19 vaccine. Just a quick overview. I'm sure a lot of these people know this, but the COVID-19 overview is SARS, as COVID-2 is a virus affects human respiratory systems. It's spread through respiratory droplets released when someone sneezes, coughs, talks, sings, all this stuff when you're in an enclosed environment, or outside. It could be outside too if somebody's close to you. What I found interesting when I did this research was that the data from several countries show that up to 20% of the cases of SARS infections are hospitalized, and 3 to 5% need ICU care. When it comes to Illinois, as of April 15th, we had 1,260,000 confirmed cases and almost 24,000 deaths to date due to COVID-19. How do the COVID vaccines work? Well, there's 3 different mechanisms. I put the picture on the right. How does a COVID-19 vaccine works? Kind of explains the mRNA type of approach when it comes to vaccinations, and then the SARS-CoV is the protein, the vector is the bottom one. So if you want to look at those while I read through the slide, maybe it'll help you understand. But when it comes to the mRNA vaccine contains material from SARS-CoV-2, and it has the immune. And then the second point is the human immune system can then make these proteins. When they get into the cell, they can make T lymphocytes and B lymphocytes, which recognize the virus. The second column talks about manufacturing the mRNA. It encodes the mRNA, encodes the genes that elicit the response from the immune system of people, right? These genes are held in a protective shell so it can get inserted into the cells. And it means the manufacturer then, the vaccine your body will genetically take the sequence and pathogen to make the vaccines and also to vaccinate your body. Now, when it comes to vector vaccines, they contain a modified version of different viruses. So it's actually a virus injected into the person. The third point is once the material's in the human cell, the immune system generates protection to COVID-19. This is a Johnson & Johnson vaccine. Some of this stuff, like from what I've learned, and others probably know more so than I do, but the mRNA is a new, fairly kind of a new technology with this vaccine. But this vector vaccine was used with the Ebola vaccine in the past. And then this protein subunit is a third way that vaccines work. Nothing's been approved yet. There's a product, I think, I forget the name of the company that is looking into this type of approach. But harmless pieces of the protein causes COVID-19 are used and injected into the body, and then your body will develop an immune system to the spike protein. All these products, as I did my research, were under the emergency use authorization by the FDA. So what that basically means is these products are not approved by the FDA yet, but they're allowed to be used under this emergency use authorization. Under an emergency use authorization, the FDA authorizes, quote, and I took this from the FDA website, the use of unapproved medical products. That's what I'm saying. These vaccines are not approved. Or you can have unapproved uses of approved medical products in emergency to diagnose, treat, or prevent serious or life-threatening disease, including those that are not adequate, approved, or available for alternatives. So they allow you to use products that may not even be studied at this point. The agency on the right, FDA, has issued emergency use authorization in the past for anthrax, Ebola, H7N97 influenza, and other types of diseases or illnesses that have been in the history of this country. So then we go on to hear about one example of emergency use authorization was in 2009. And this was during the pandemic, the H1N1 pandemic, where Tamiflu was a drug that they said was approved or could be used to treat that. But the issue was, in that first paragraph, was an existing dose already approved by the FDA was already there, but what was the dose for infants for the virus? And Tamiflu at that time had not been studied in infants. So during this pandemic, the FDA produced a recommended dosing for young infants under the emergency use authorization. And the authorization was established and provided official recommendation to clinicians to administer Tamiflu to infants. So they didn't have the dose, but the emergency use authorization allowed the FDA to basically come up with a dose that they thought would be appropriate. Ordinarily, as the third point says, it might require special studies to produce a dose for infants, but there was an urgent time-sensitive demand, just like with COVID. This was a reasonable approach based on their expertise and how babies would metabolize the medication. So it was reasonable, and they came up with a dose and said, this is what we're going to use Tamiflu in infants for in 2009. The availability of these vaccines are through the current COVID vaccines are through the emergency use authorization. When they first approved, or I won't say approved, but these drugs, when they came out, were indicated. Pfizer was indicated for 16 years and older, 2 doses, we know about that, 21 days apart, 5 doses per vial. Moderna was indicated for 18 years or older. But now they've looked at, as of the end of March, can these drugs be used in 12 to 15? And Pfizer came out, and I think Moderna did too, saying they were safe and effective. So more than likely, if not by now, the FDA is going to allow emergency use authorization for children 12 to 15 for these vaccines. One of the vaccines I talked about before was the Johnson & Johnson vaccine. The interesting thing about this is it's once dose, which we all know this, who's listening to this. It's indicated in people 18 years or older, single dose. It's a vector vaccine. We can get 5 doses per vial. The data is 72% efficacy, but if you look at the data, I've heard this drug has been used in more difficult to study, difficult to treat patients with different variants, and I know South America and the other variants were studied in this drug. So the numbers may be different, but from what the experts are saying, they're all very good drugs to be used when it comes to vaccinate against COVID. The AstraZeneca vaccine, COVID vaccine, is not currently approved in the U.S. The data shows what this is: 76% efficacy against symptomatic COVID vaccine, 100% efficacy is in severe clinical disease and hospitalization. I think that data, that 100%, also applied to Johnson & Johnson's vaccine. One of the things, though, that was concerning was the Institute of Allergy and Infectious Diseases questioned the accuracy of their efficacy results. When it was informed the UK-based company may have included information that provided an incomplete view of the efficacy data. And the point was that this threatened to erode the trust in the COVID vaccine I have on the right, but then they ended up working out. And hopefully this product will be approved soon, and that the data was, corrected, and looks like it's going to possibly be a good drug or vaccination. This just goes through this slide about the Illinois vaccination distribution. It goes in phases. This is how public health rolls these things out in the states, and they do it throughout the whole country. Every state has their own ways of doing it. December 15th was the first vaccination rollout to healthcare workers, long-term care facilities. January 25th were essential workers, and people 65 and older, your elderly patients. Then 1B, February 25th, were all your different categories of different illnesses and diseases in people. And 1C was essential workers, bartenders, hairstylists, everything else that's in that category. April 12th, though, people greater than 16-year-olds can receive the vaccine. As it says, there were 6,290,000 doses of COVID vaccine have been administered in Illinois. It's a 7-day rolling average, but this was as of April 4th. They've had over almost 6.3 million doses administered. One of the things legally they look at is pregnancy considerations. Should people who are pregnant be vaccinated? What they know, what they've said, the data shows pregnant women are at increased risk for severe illnesses of COVID-19. Previously approved viral vector vaccines like Johnson & Johnson and the Ebola virus have been administered in pregnant patients during trimesters with no adverse pregnancy. So they've concluded, this was stuff from the University of Chicago Medicine, receiving the vaccine will not impact the patient's fertility. The American Journal of Obstetrics and Gynecology, March 25th, they looked at 131 women who were enrolled in a prospective cohort study. Basically what they saw was the vaccine-induced antibody titers were higher with those induced by COVID-19 during pregnancy, significantly higher with vaccines than if they just had COVID themselves. It's recommended on the right that available COVID-19 vaccines should not be withheld from pregnant women who wish to be vaccinated. You should obviously have a conversation between the pregnant patient and their clinical team to decide if it's worth getting the vaccine at that time. What they say, though, the recommendation is if they have the dose, then become pregnant, they should still take the second dose. The theory, this is again, University of Chicago, vaccinated during late pregnancy, it's likely that antibodies could be transferred from the mother to the fetus, which may help provide some protection against the COVID vaccine for the fetus, or for the fetus, the baby. One of the things that has come up is drawing additional dosage from vials. This question talks about it on the left in the blue. Is it possible to obtain an 11th dose from the multi-dose of Moderna COVID-19? Some providers may be able to obtain an 11th dose from Moderna, and it may be used if it's truly a full dose. Basically, I'll read the 2 points on the right and then give you my opinion. Pfizer submitted for an emergency use authorization support to the statement that there are 6 milliliter doses, 0.3 milliliter doses in a vial of their vaccine. They used to say it was 5. And Moderna said, followed up, said also there's 11 doses obtained within their vaccine. So what they're saying, the FDA, is it's okay to draw that 6th dose or that 11th dose. But if it's a partial dose and you have to go to another vial to get to fill that whatever 0.3 mil dose, you can't do it because you're mixing vials, preservatives, lot numbers. They don't recommend that you do that. But if you can draw up 6 doses in one vial, it's okay, or 11. What they're doing with these doses, how they're getting them, is this low dead volume syringes. This is January of 2021. Vaccination centers across the country received their first federal shipment last week, supplies to help them extract the 6th dose from the Pfizer COVID-19 vaccine. They have this low dead space syringe versus a high dead space syringe. The low dead space volume syringes and needles can be used to extract 6 doses from Pfizer. So what they did, the White House enacted this Defense Production Act to ramp up manufacturing these low dead volume syringes. And so they're sending these syringes out so they can get these extra doses out of each vial of Moderna and the Pfizer products. One of the things I thought people would want to maybe find interesting was, can employers mandate that employees get the COVID-19 vaccine? And I grabbed some data from other things that happened throughout the years, but also in this case, there's a conclusion is that if someone who works, like, one of my thoughts were, what if somebody works in a hospital? If somebody walks into a hospital, and you all know this, and they're infected, they have the ability to possibly infect others, whether it's coworkers, patients, or anyone in the hospital. So what it is then is the employer, if they want to mandate vaccinations for their employees, they have to have a determination that an unvaccinated individual will expose others to the virus at the work site. And then if you look at the point on the right, the American Disabilities Act allows an employer to have qualification standards that require that an individual should not pose a direct threat to the health safety. So that's when they can say, well, to the individual, maybe you don't need the vaccine if they're not a direct threat. But if the employer thinks that the employee is a direct threat to others, and then the second bullet point on the right defines what a direct threat is, the employer must show that an unvaccinated would pose a direct threat, which is a significant risk of substantial harm to the health or safety of the individuals or others that cannot be eliminated or reduced by reasonable accommodation. So in other words, if the employer can't reasonably accommodate the person who they're making get the vaccine, then the person has to get the vaccine, is what they're saying, according to this. The point on the left, the second point, is that if an employer determines that an individual who cannot be vaccinated, the employer cannot exclude the employee from the workplace unless there's no way to provide a reasonable accommodation. So if they can't provide a reasonable accommodation, then the person must get vaccinated in this case. One of the things, the most current hospital was a big hospital, Houston Methodist Hospital, announces mandatory COVID-19 vaccines for their employees. This was April 1st. There's 26,000 employees at this hospital. They issued that it was mandatory that COVID vaccines are appropriate on both the state and federal level if they adhere within the, this is what they came up with. And then they concluded that staff, though, who have religious or medical concerns about getting the vaccine can submit an exemptions for review by their committee within the hospital. And that committee would then say, well, we'll accept this. So you don't have to get the vaccine, or you're going to have to get the vaccine. I'd be willing to bet nobody got an exemption, but I don't know the data on that. So then they rolled out, Houston Methodist Hospital published, what should managers do? Managers have to be until April 15th to receive at least 1 dose of COVID-19 vaccine. Flu vaccines are already mandated in the Houston Methodist, and there's the quote from the CEO of Houston Methodist Hospital, that part of Houston Methodist management, we must lead by example. So they want to be the front runner when it comes to vaccinating and mandating vaccinations for their employees. Another case was an example of mandatory vaccinations. Now, this was by the city of New York in 2020. And New York City Department of Health basically said there was an outbreak of measles within certain areas within Brooklyn, New York. And they came out and said that any person over the age of 6 months who was living, working, or attending school had to be immunized against the measles, against measles. And then they talk about on the right, measles outbreak, these resulted in more than 8,700 additional vaccinations in those boroughs within Brooklyn, New York. So in other words, this mandate put up by the New York Department of Public Health increased the amount of vaccinations for measles that were given. So then they went on in the presence of Williams lacking MMR. Again, they would say it created, this is what the courts were saying because someone took it to court. And they said it was unnecessary and avoidable risk of continuing the outbreak, continuing the outbreak. Therefore, they try to say it was a nuisance, but the New York people law said, no, you have to give this vaccine. It's not a nuisance. Some people try to argue they had religious rights to not get this measles vaccine. The court said it acted by repealing the religious exemption from mandatory vaccination for school children. The elimination of religious exemptions took effect in June. And then they tried to say they were forcing them, the people that filed a case saying they didn't want to get the vaccine, that they were being forced to do it. But then they ended up changing their opinion, saying the petitioners conceded that the resolution did not require forcible vaccinations. Illinois has many different parts of the administrative code or the rules within Illinois that requirements for healthcare workers to basically have access to immunizations. If you look at the first point, 89 Admin Code 56, whatever, incorporating the requirements of the Code of Federal Regulations, federal law requires employers to make available hepatitis B vaccine and its series to all employees who have occupational exposure. So now they're looking at it from the employee standpoint. How does an employer protect the employee? And then when it comes to hepatitis, this rule said the employer must ensure that hepatitis B vaccine and series and follow-ups is available at no cost to employees. They're not mandating they take it, but they're mandating the employer to have it available. The Illinois rules do. Then you look at the influenza vaccine in the second part. It talks about influenza season. Each healthcare setting shall ensure that all healthcare employees are offered the opportunity to receive seasonal pandemic influenza vaccine. So it's not like they're mandating again, it has to be available. Then the long-term care facilities, very similar. Each committed person shall be immunized as prescribed by the physician influenza vaccine for all residents age 65 and older. This just talks about inpatient vaccinations of people that are 65 and older. One of the other things I was trying to find out, which I was working on as far as research, what I thought would be helpful for pharmacist learners about pharmacy technicians administering COVID vaccines. The only thing I could find, and maybe Garth knows more about in Illinois, but the Department of Health and Human Services came out for guidance for COVID-19 vaccinations for qualified techs. And there's two things to consider, right? When it comes to pharmacy technicians vaccinating patients. There's a supervising pharmacist. There's also the pharmacist in charge in every pharmacy. But the role of the supervising pharmacist when it comes to technicians providing vaccines, their role is to order the vaccines, be immediately available, comply with all record keeping that's required by the state, comply with requirements regarding and reporting adverse events, just like you would with other vaccines, and comply with the requirements of the CDC 19 provider agreement, COVID-19 agreement. Technicians, though, what they're recommending, they have to complete ACP approved training program that includes injection training, treatment of emergency reactions as a result of vaccines, be currently certified in CPR, complete 2 hours of approved immunization related continuing pharmacy education. And if the patient is 18, inform the caregiver of the importance of a wild child visit with a pediatrician, a follow-up. So that's what Department of Health and Human Services is saying technicians have. That's their role. So then I found a study where they asked patients, what's your perception of pharmacy technicians being immunizers, giving you an immunization or a vaccine? How does the patient feel about that? And in the study, we're trying to assess patient perceptions, when they receive the vaccine from a technician. And the methods were they basically interviewed the patient before they received their vaccine from the technician. They were walk-in patients from 3 different community pharmacies in Illinois and in Indiana. And the results in the red was participating patients supported the pharmacy technicians in their ability to immunize. They believed that as a result of technicians providing immunizations allowed pharmacy technicians to become immunizers. Therefore, if they were immunizers, it would decrease the wait time to get the vaccine, increase accessibility of vaccines, balance the workload of the pharmacy, and allow the pharmacist, which I think is important, the pharmacist to focus on other roles such as counseling patients. What are liability considerations? Obviously, the supervising pharmacy is responsible for everything. And the quote I have from the IDFPR statement of June 2019 is the pharmacy and pharmacist would be 100% liable for acts of the pharmacy technicians, just as they are currently, which is true. They're responsible for everything that goes on in the pharmacy. A little bit I talked about here was the pharmacy malpractice insurance. Obviously, if people do have technicians vaccinating, they want to make sure their malpractice insurance covers that. Most of them do, from what I saw and read. Then there was a readiness preparedness act to add additional categories to qualified persons. So now here's what they did with this act, this federal act, was to get people more vaccinations available. They amended this act to allow, in the red, any healthcare provider who's licensed or certified in a state to administer COVID-19 vaccines. They can go to any other state and give it, as long as they're a physician registered nurse or practical nurse whose license expired, or if they expired within the last 5 years, they can also step up and give the vaccine. But those people who have been expired for 5 years, have worked for 5 years, have to go through some sort of training to administer the vaccine. So this is what they're doing, just to try to get people to get more vaccines, is trying to allow for people who from other states to come in and administer the vaccine if there's a need for that. That's it. The post questions are here. I can take questions after this. What is emergency use authorization? The answer is B, the use of unapproved vaccine medications in emergency when there are no other treatment options available. During my points on the bottom, during a declared emergency, the FDA can decide that it's worth releasing an unapproved product for use, even without all the evidence that would fully establish its efficacy or effectiveness and safety. If there's evidence that strongly suggests that patients have benefited from a treatment or test, the agency can issue an emergency use authorization to make it available to the public, and the benefits must outweigh the risks of the treatment. Question 2, can employers mandate that their employees get the COVID-19 vaccine? True. Should the employee wish to work in person at the place of employment, the employer is within their rights to mandate that the employee present evidence of inoculation for COVID-19 vaccine. Guidelines regarding religious and medical exemptions should be followed based on the Equal Employment Opportunity Commission's guidelines. If an employee refuses to get vaccinated, the employer must provide accommodations for the employee, which is what I showed on the one slide. Is it currently not permissible to obtain extra doses of vaccine from vials for administration? False. Both Pfizer and Moderna have approved extracting extra doses from the vaccine vials. It's not permissible to combine, though, remaining contents from multiple vials if there's not enough for a full dose in one vial. Pharmacy technicians can independently administer the COVID-19 vaccine. False. Yes, the tech can administer the COVID-19 vaccine so long as a supervising pharmacist is present and available, and both the supervising pharmacist and the technician follow the guidelines from the Department of Health and Human Services. Take-home points. Employers will be allowed to mandate that their employees should receive the COVID-19 vaccine should the employee wish to work in person. Point 2, pharmacy technicians can administer COVID-19 vaccines under certain circumstances. And 3, manufacturers have authorized the use and administration of extra vaccines obtained from vials. There's my resources. If anybody they want to look anything up, here's my contact information, and I'm ready if anybody has any questions or if anybody wants to have a discussion on some of the points or has anything to add. I'm willing to take questions or listen to what other people have to say.
Thank you,
Hi.
Jenny. Go ahead.
This is Christina Petricu. I'm in the process of finishing a Tech CE program on the PrEP Act, so I wanted to add a little bit of clarification to some of the information. The PrEP Act was created for emergencies, but it is the source of eliminating liability for certain things. And so in the past year after the COVID epidemic started, they enacted the PrEP Act, and which ultimately led to the EUA coming out, and Amendment 3 or 4 of it in August of last year is what allows the pharmacists and pharmacy technicians to be doing the COVID vaccine. Then the guidance came out subsequently after that in October, and they keep clarifying and keep adding healthcare professionals. But on the pharmacist side, the pharmacist still has to be CPR certified and has to have completed 20-hour program with hands-on administration of the vaccine as part of the training program, where that is probably for all practitioners that have finished pharmacy school in the last 10 years. They've all been trained because it is now currently the curriculum, and you're certified for immunizations like in your second or third year of school before you go on rotation. So it might not have been emphasized as much, but that is still a requirement as well. And the interesting thing, prior to this amendment, we had maybe 3 states that have allowed pharmacy techs to immunize. Washington State was in the process of a pilot program, and Iowa as well. And then this now supersedes anything that the state has. So, for example, in Illinois, where we didn't have the allowance of availability of techs being able to do the immunizations, as of this amendment, it supersedes any law. So they are allowed, if they've completed the training, to do the immunizations. There was another point and I forgot it. But sorry to add all the clarifications. It's just really fresh in my mind because I'm in the process of it. The other, sorry, just remember, the other part is not just the COVID vaccine, but because all these pediatric practices closed, this act also, the amendment also allows us to administer pediatric vaccines to anyone less than 6 months old through 18. And so that's why that well visit is a requirement, because you can do certain vaccines. So it ends up being like the last dose of the DPT and MMR, the HPV vaccine, like it's 6 or 7 vaccines that we're now allowed to do, which prior to this, I think Illinois allowed at age 10 and above to be done in the pharmacy, but now we can go down lower. But I have not seen any procedures for anybody in pharmacies implementing the pharmacy tech aspect of it. At least not yet. I haven't been looking as much for that. I was just doing the research on the PrEP Act.
Interesting.
It was fascinating. I had no idea about all of the legal aspects.
There's so much to it, and I just found things I thought would be of interest, but there is so much behind all this. It's unbelievable.
Oh, I love some of the topics you went over. I'm like, oh, I got to remember that. I need to remember that too.
Well,
Hey,
I don't know. Oh, go ahead.
Oh, Jay, it's Dennis Bryan. A quick question. The supervisory for the pharmacist that has to be around when the tech does do the immunizations, do they have to be physically there, or is a remote situation acceptable?
Oof, that's a very good question.
Because I know there are certain chains looking at the remote aspect.
And I don't know of anything specifically, because my as I think about that, there's remote dispensing going on with certified techs, with telepharmacy and all that stuff. It's almost like, does that type of model apply to these technicians, certified techs that are administering the vaccines at a different location? So one side of me would say, and I don't know if this is the right answer, I don't have the answer to that, but one side of me would say, if they allow this remote dispensing with the video visualization of what, the home pharmacy, let's say, with the pharmacist there, why couldn't they do vaccinations?
Right.
But I don't know.
There hasn't been any official declaration from the department on that. I know in discussions on that, there have been, best practices. I would state, if you were going to have a pharmacist remotely viewing a technician administration, one, you need to make sure there's at least 2 staff members there. No one should actually ever be administering a vaccine by themselves, and that's including the pharmacist. Secondly, the pharmacist from the home store would need to be viewing the entire aspect live through the whole process. But again, this would just be applying to telepharmacy. we don't have the ability to remote view activities that are not in a pharmacy department. So you couldn't just put body cams on technicians and send them out to long-term care facilities. So if that's what some of the big boxes may be thinking, that's not going to happen.
Well, I guess the question I have too is, what actually dictates guidelines for what qualifies someone for remote? In other words, is there a distance factor of, like you have to be so far apart in order to qualify as a remote pharmacy, or is it a matter of just a half a mile? Does that qualify? And I don't know if that's all been addressed. And Garth, I guess you'd know better than anybody.
No, there's no definitions on that, but you do have to have the definition of, you do have to be classified as a telepharmacy or a remote dispensing location or remote counseling location with the department. You just can't decide, well, it's convenient for me today not to be here, so I'm going to remote view everybody. So there has to be a designation by the department and an inspection by the department that you meet the needs of being a telepharmacy.
Does the department then have those guidelines laid out somewhere for view?
Besides what's in the rules, that's all there is. There's nothing states of what you have to meet. You just have to meet the inspection guidelines.
So it's up to the inspector at the time of that the institution to decide whether it's yes or no.
Yes. Yeah, we're one of the few states, well, actually, we're one of the more liberal states when it comes to what you can do under telepharmacy aspect all globally. But we also, in that same respect, also one of the few states that have the least restrictions. So we don't have a lot of regulations of what can and cannot be, what cannot be done. We have a lot of what can be done, but what cannot be, not as much on what cannot be done. Ginny, I see that your hand's raised.
Thank you.
Hi, I just wanted to comment on that question and those concerns about the telehealth and supervising technicians in that manner. I think the risk that you would take in not having a pharmacist be there in person is when things go wrong, and just spending the afternoon administering COVID vaccines at the clinic. A few situations came up where there needed to be someone that has that clinical training and judgment to be able to assess when someone isn't feeling well, take blood pressures, that in decision making in that manner. And so I'm afraid with telehealth that might be difficult. Or telemonitoring of technicians administering might be difficult to carry out that kind of task.
Right, and Ginny, that goes back to the whole thing with the legal liability, because as Jay stated, it's on the pharmacist. And so, and that's one thing that we're in a new environment now with technicians being administering. Jay mentioned that there was one insurance vehicle that's available now for technicians for liability under HPSO. There's also one available now through Pharmacist Mutual. Right. So, this is an expanding aspect. Rupesh, I saw that you...
this is Chris. I just had a question. So from that standpoint, if the PrEP Act removes liability, does the liability coverage thing even come into play?
Even though the PrEP Act removes liability, there, as Jay will be glad to tell you, could probably talk hours on, that does not prevent you from being sued.
Right. Well, and I'll add, like I tell clients, not that you believe this, Christina, but people will say, well, I didn't know I broke the law, or the law doesn't say I can't do that. And I remember I worked for a lawyer. He said, well, if it's not written in the law, it's legal. And my argument would be, it doesn't matter. As a former prosecutor of the department, if the board thinks it's not right and unprofessional and doesn't meet the standards of pharmacy care based on there, you still have to go through the process. You may come out a winner, but kind of to Garth's point, it may not protect you. So it's like, that act. So people might think, well, I can do this under the act, but you're still going to go through the motions of meeting with the board and going through the whole, I'm not saying you're gonna, but you could. And that's never a good feeling.
But the one thing, like Christine, to your point, it's still when and if, because it's when and if, because the PrEP Act amendments will be rolled back at some point because they have to be. They're only
October
good every 90.
24th or the end of the pandemic.
Right. Yeah.
October
exactly.
2020.
Right. And they can keep renewing them. They've renewed them a couple of times. You know, Illinois, you know, starting January 1 of 2020, technicians could immunize in Illinois. And that was in the Pharmacy Practice Act. So we don't have to do anything additional once the PrEP Act amendments are rolled back. So the only thing that's going to roll back for pharmacy is going to be our expanded authority to prescribe, because we can prescribe vaccines right now. And the administration and the expansion of that age range, that 3 to 9 year olds, is going to be the big difference. And then the additional vaccines for 10 to 18 or 10 to 14, excuse me. So, you know, those are things that hopefully, you know, as processes go, we'll be able to, you know, get permanently into the act, but those are other discussions. But it's great points to bring up. Rupesh, I know you've had your hand up for a while, so go right ahead.
Yeah, I had a situation today where, you know, in my consent form, I asked people for a patient ID or some sort of a state ID or whatever. But I had a group of 4 patients that showed up for their shot, and they basically were undocumented residents of Illinois. The only thing they had an overseas passport. I mean, I took care of them. I did what I had to do to take care of them, but was I supposed to, or was I not supposed to?
According to HRSA, you are allowed to, and the PrEP Act amendments, you're allowed to immunize anyone who's eligible. And right now, pretty much, and it's definitely after April 12th, it's pretty much available. So if they met the group criterion, you are able
they
to
met all
immunize.
met all the criteria. There were 2 of them were part of 1B and 2 were part of 1B part 2.
Right.
And so, that was fine, but it was the documentation was an issue because there were non-documented residents.
Right. And so there's nothing that would prevent that. And actually, some of the health protections of other Illinois laws would still mandate that you would have to treat them. So there's nothing that you didn't do anything in error at that time. So.
Okay, cool. All right. Just wanted to clarify that. Thank you.
And then you have to apply for billing or coverage of the vaccine administration through something from HRSA. I think there's a particular billing practice that you have to follow for those patients.
Right. Great discussion, everyone. Any other questions or comments? Oh, Nita, I said that you see in the comments here, do you physically need to watch the tech give the vaccine? That all depends on how you train your technicians. I mean, I would say you use your professional and clinical judgment there. And Jay, you can definitely expand upon this in performing duties. I mean, the techs are allowed to do anything that's trained. We don't physically watch them on every task they do in the pharmacy today. But so it does free up your duties because it is allowing additional personnel, just like you would have student pharmacists administering, which have been allowed in Illinois for well over a decade. But it's just, you have to use your professional and clinical judgment and proper training and oversight of staff.
Garth, I have a question.
Yeah, go right ahead.
Okay, it's not happening yet, but there is a religious organization, it's a Hindu temple, and they are going to have a picnic in July. And they are asking pharmacists and nurses to volunteer, and they would like to give COVID vaccination. By that time, maybe it'll be freely available. So I'm just wondering, a pharmacist who is not working in his pharmacy but is certified to administer the vaccine, can they go to such a facility which is not actually a medical facility? It's like a picnic ground, or it's a religious institution building. Can they administer the vaccine there?
Yes, they can, because you can do that under the Act today.
Right.
Pharmacists have the ability to provide immunization care outside their brick and mortar walls of their building.
Okay.
Right.
Can I just add, Garth? Hi, it's Lydia.
Sure, go ahead.
Can I just add, if you do that, though, I highly recommend, just in general, that you have your own liability insurance. If you are administering within your brick walls of the pharmacy, you are covered by the employer's insurance. I personally still carry my own insurance even when I'm working in a pharmacy. But if you're doing something outside of an employment relationship, you absolutely should have your liability insurance just in case.
I think
There's
that's
also guidance on the CDC site to register as an administration site. That's kind of one of these off-site mass vaccination sites. I didn't look at the details of that, but I think because it's COVID vaccine and they're trying to track it and make sure distribution's appropriate and the storage peculiarities, they do want you to register as a site, even for something like that.
And Bedre, you bring up one of my biggest points that I try to drive home with students, and Jay can probably, again, talk for hours about this. Always have your own liability insurance. Remember, the liability of your insurance covers the employer. It does not cover you. And so you always need to have your own liability insurance.
I would agree, whether you're working in the pharmacy or outside of it, even in a chain. That's what I think. Should still have your, and it's not that expensive really relative to what could come your way. I don't even know how much it is. It might be $300 a year or something. I'm not even sure.
150, Jay, or 160, something like that.
Yeah, probably worth it.
Any other good questions or comments? We've got a really good discussion, but I know we're getting close to our time, so. All right. Well, Jay, thank you very much for this wonderful presentation. And I am going to take over screen sharing so I can show the code, but I'm going to stop the recording first.
Oh, I just got.
Okay. So thank you again, Jay, for a wonderful presentation. And I quickly, as I know we're getting close to our time here, but I do want to kind of go over some quick updates. As we know, we're still hitting an increase in cases again. I thought there for a while we were finally starting to see the downward trend, but as we know, I think people are getting tired, as we all know, of the pandemic limitations. I think the impact of the misguidance of individuals who went to spring break in Florida will have many deaths on our hands in many states. And I think we'll have to adjust with how we handle those type of situations going forward. Public health guidelines in states like Florida just not willing to help is going to make this pandemic continue to worsen. Here in the state, we had another almost 3,800 cases today. We're on an increase again. As you see there on the heat map, we're starting to heat up and get darker red with cases. We were actually starting to cool down. I mean, we were actually seeing a downward trend. We were almost, I think here in Sangamon County, we almost had a day where we were just close to getting to the single digits, which we haven't seen since summer of last year. So, I mean, we were starting to see progress, and I think we will as we get more people vaccinated, but we still have to toe the line. And even once we're vaccinated, it doesn't mean that we can just do whatever we want. We still have to wear masks and wash our hands and keep distanced. As you see here, vaccine data, the state's gotten 8.4 million doses. With conversations we've had with the state, there's about 900 pharmacies that are now on board with being able to provide vaccine. We all know that the vaccine gates have opened up a lot over the last couple weeks. It's still nowhere near what we need it to be. I left last month's data in there, so we've grown almost 6 million doses since the last time we met to the beginning of March. So we have had significant progress. We keep impressing upon the state that we need to keep utilizing all pharmacies. it's concerning to me that, they continue to use these mass vaccination clinics with National Guard. But we know that the state's getting 100% match dollars on the National Guard, and that means they're also getting 100% of those administration fees right to the state budget. So that's also reasons why they're not using healthcare providers. But it's also very disturbing when you have articles come out that show that just a little over 30% of the National Guard are actually getting vaccinated. We have a significant population of the Guard that are not getting vaccinated. And to have that high percentage of the individuals running the clinics aren't vaccinated is irresponsible. As you can see, here is the heat map of counties that are getting vaccinated. It's definitely seems to be a lot more equalized as you compared to early March last week, where we had some counties that hadn't had any vaccinations yet. But we at least have some blue in colors. There's still some counties deep south that really need help. And I think if they fully embrace the pharmacies that were available in those areas, we could definitely get this state up and running a lot sooner. Just additional data on here for inventory. I thought it's interesting that we've been very good about managing doses, that we've at least reported wise have only had 2,600 doses. One thing I do want to bring up, also looking at some of the demographic data, we're still hitting about the same population mix of demographics per our census, but we still need to make sure as pharmacists that we're taking opportunities to get into communities of need and communities of color that may not have readable access to the vaccine, and ensuring that we're getting our patients in all of our community opportunity to the vaccine. One thing that I want to bring up is make sure when you're training your staff that you're also putting in the importance of protecting the vaccine supply, and most importantly, protecting the documentation of vaccine records. We have had a couple of cases here in Illinois now that I know are being investigated of falsification of vaccine documentation. And I know some of this stuff is available on the internet. This, of course, is not only illegal behavior because it's falsification of medical records, it's unethical behavior, and something that is definitely not tolerated by the association. And if we hear anything about it, we're sending it directly to the board for further investigation.
Wait, sorry, Garth, what was that again?
Illegal documentation of falsification of vaccination records.
Okay.
There have been individuals producing cards exhibiting that an individual has been vaccinated and they haven't. I do not understand the ethical argument for why someone would want to have a falsified documentation when you could get a treatment that can make all of this go away and keep you out of the graveyard and help get society moving forward. This is backwards momentum, and it looks bad on the profession. So yeah, Sam, people are stealing the CDC cards, and they're actually sometimes being done by pharmacy staff. And so there's been some documentation in other states, but we are now seeing it. I at least know of one case that we have brought to the board's attention that's in Illinois. Again, just a reminder to everyone, a lot of the stuff that Jay talked about, including the amendments and APHA's reimbursement and billing guide, APHA's breakdown and summary. They have a summary chart on the vaccines, everything to become an eye care provider. If for some reason you're not an eye care provider by now, is in our IPHA resource guide. You can find that on the IPHA.org website. I do want to bring your attention to a project that APHA and NASPA has rolled out as of last month. And this is on the pharmacist's fundamental responsibilities and rights. And this is talking about the workplace. This is a draft document that is an extension. For those that remember, back in 2019, there was a profession-wide consensus conference on workplace issues. IPHA was fortunate to be part of that. And out of that came 50 recommendations. APHA, working with NASPA, which is the National Alliance for State Pharmacy Associations, we took the 50 recommendations and tried to come up with a new kind of code of ethics document for the profession. And this is our first draft to the profession. There have been town halls, listening town hall sessions that APHA has held last night and tonight. You can still provide documentation of any of your comments to APHA through the end of the month. And I highly encourage you to take a look at this document. It's a couple pages long. This is just the first page. Go through it and please provide documents, because as president of NASPA, I want to make sure that this is a strong document for the profession nationwide. And as your executive director for this association, this is a tool that we're going to use to make policy changes. IPHA has been very adamant that we're going to be working forward with helping out with trying to change some of the workplace environments. And just to let you know, my power flickered. We're getting hit with a storm here. So if I could suddenly go, you know, our power went out. So please do take a look at that. Quickly talking about our legislation. This is our action bill tracking timeline. If you look at the third bill here, House Bill 135, our expansion of contraceptive services and women's rights in pharmacy, is out of healthcare licenses and will be on the House floor. There will
7
be
years.
exactly
7, 8, 10 years. Yes.
There will be an amendment to this bill that will provide religious exemptions for those who feel they need to enact that. Even though the bill was voluntary anyway, but we're adding the language in there. It keeps it moving. And as you know, our Senate Bill 2008, which is our PBM bill, and its companion House Bill 3630, the Senate bill is going to be our primary focus for the rest of the spring. It is going to be heard in Senate Insurance Committee next week. We still do not know a date, but it will be heard so we can get it moved to the Senate floor. With that, we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, I think 15 co-sponsors now, including 6 members of the Insurance Committee. Glad to see Chapin Rose on there. He is our first Republican of the Insurance Committee, and he signed on today. So we have 25% of the Senate now co-sponsoring the bill. So let that sink in for a moment. So we're gaining more and more support on this. This is bipartisan support, but we really need to push on members of the Insurance Committee. And please do be reaching out for co-sponsors to your senator. We do have the IPHA Advocacy Center that's now online. That's powered by Voter Voice. And you can sign up for your co-sponsors through that. And also sign up for Virtual Legislative Day, which it's free, so no one has no excuse for not being there. It's going to be on April 21st. And we're going to have another town hall, just like this format tonight, next Wednesday night on April 14th to take you through Legislative 101 and to talk about the different bills and what to do, how to and how not to have a conversation with your legislator. So we'll go through those next week. But again, do sign up. It'll also give you the opportunity through Voter Voice to be able to sign up for an appointment with your legislator. And I do want to show you what that looks like real quick.
Hey, Garth, just a real quick question on the contraceptive bill.
Yes, sir.
Where is the Illinois Medical Society stand at this point?
They are neutral and have been neutral and staying neutral.
Okay, that's as good as anything.
Yes. Yes. Our biggest hurdle right now is the Republicans. They're wanting to have an age limit on the bill of 17 and older. But our position is we want to get it passed. And so, but I do want to say that we're still supporting trying to make it as expansive to all women as possible. I think it's foolish to think that women under 17 don't have sex in the state. So I think we have to be realistic with what's going on in society. So just because they don't want to recognize that reality doesn't mean it doesn't exist. Um,
I mean, not those Republican senators' daughters, Garth.
right, I know. But if you go to IPHA.org, and we have a special link here at the top for IPHA Advocacy Center, and conveniently right below it is the vaccine resource guide, just for your convenience there. But also in the title bars, as we go forward, the Advocacy Center is right here under Advocacy. So you click on that, and it goes right to our call to actions, which is right now asking for co-sponsors for Senate Bill 2008. You can sign up for Legislative Day. You can also sign up for alerts for advocacy only. This is just for advocacy alerts. You can look at various legislation, including our key legislation, which is highlighted here. And if you do not know your legislators, we have a very easy tool. You'll put in your zip code, it'll ask for your street address, and then it'll identify for you who your elected officials are. And it easily allows you to be able to send a message directly to them from that prompt. But if you look at signing up for Legislative Day, before you fill this out, please do click and register for each of these Zooms. These are going to be the Zoom meeting links registration, so please complete these before you complete this registration. And then also on the co-sponsors, this brings up a pre-made up message for you, so you can take a look, and this is giving you information about the bill. And then here is your pre-template message. You can change some of this. We do ask you to not change any of our content, but for you to add and personalize it. And then you can go ahead and send that to your senator. But any other questions for the good of the order right now? All right, everyone. Well, I thank everyone for your time this evening. Remember, we'll see you all next week for Legislative Day 101. And then we have Legislative Day during the day on Wednesday. And then we'll have our monthly town hall again the first Wednesday of the month. And if you know of any pharmacists that are still needing immunization training, we just did technician training today. But we have pharmacist training coming up on the 24th.
Hey, Garth, could you make that link available for the ethics message between APHA and that just came up with?
Oh, yes, I'll let me send that over to you. Hang on a second.
I mean, I can just download it from the
Oh no, yeah, I'll put the link here in the chat.
from
Just
IPHA. So
yeah, give me a second to pull it up here for you.
no problem. Because that way I can just pull up the email and then go from there. So that would be easier for me.
We had 14 in the tech training today.
Good.
So
Is that going to be offered a second time?
I don't know if this was actually our fourth time offering it. I'm not sure if we will offer it again for a while. We've been pushing hard on a lot of these trainings. Basically, about every 2 weeks since the first part of January, we've either been offering the technician program or the pharmacist program. So we'll take a look at that. We're trying to offer some of the other programs during the month of May. So we may end up taking a break and coming back in June for those. But if we end up getting enough interest, we may go ahead and put that out there.
Garth, are the big box people doing their own thing?
Yes, they have their own license. Like in the state of Illinois, there's 4 licenses that I'm aware of.
Okay.
Us, and then OSCO, because OSCO was originator of the program,
Okay.
and CVS and Walgreens.
Okay. Thank you.
No problem. Dennis, I'm having problems getting right to that. So I'm just going to
No,
send
that's
it.
why I said just email it to me and
I'll email it to you. Sorry about that.
make
I
it
should have
easier.
had that pulled up. So, all right, everyone. I really appreciate that. So yeah, we'll, if there's interest in technicians, please call the office. So Jamie and Kim, or actually talk with Kim so we can keep a list, and we'll see where we can get, if we can get another training scheduled here pretty soon. Okay, everyone. Well, thank you.
Thank you, and
All right.
stay well grounded.
We're going to have to, because it's definitely surging up here. So
Well, I've got nothing up here, so you can keep it.
Yeah.
all right, everyone. Have a great evening.
All right.
Okay, you too. Thank you much.
Bye-bye.
Bye-bye.
Night all.
Good night, everyone.